Hi guys, hope you're doing great. So I hope you are enjoying the rains and welcome to the session. I think you are rested, enjoying after the end of the exam and speculating what your future has in store for you. But it's always going to be good. So hit the comment button and let me know what is the first thing that you Googled after the exam. It was a question of POSCO, and the remaining options are which I thought are logical ones. I included this because there were a couple of irrational ones, there were a couple of petty laddu MCQs, scoring ones. So it's a mixed bag, right? Bouncer, short pitch delivery, then a laddu wall which you can hit for a six. So yeah, Kaushal, I can understand the silly mistakes. So yeah, the best thing is sleeping. I think most of you would have slept, I think, straight 14 hours, 16 hours, something like that. But yep, I understand that the fatigue starts coming in. So yeah, I think the POSCO cutoff was the most Googled thing after that. I mean, we would have not anticipated, nobody would have anticipated a question like that, but then this happens. Yeah. I mean, because the ERI is rave nowadays. I know you guys are, you belong to a different, I would say, generation is the same, but you belong to a different class, so you would not be going for it. Okay, good. So fine. I think I've had comments and we can get started. This starts at 8 p.m. today for those of you who might be interested. Otherwise, let's now get into the groove and start our. I have total of 191 and I'll be discussing them quick before you. So this session is mainly meant for those who have actually went for the paper, sat to the paper and are aware of the kind of things that have been asked. So this particular question, I'll zoom it in slightly, basically talks about a ventilation perfusion curve. And as you move towards left, that is point number A, there's a problem with ventilation conditions like status asthmaticus. And as you move towards point number D, there is going to be a problem with the perfusion and the values tend to become infinite or substantially elevated. So since the question was on a massive pulmonary embolism, the wordings of this might be a little offbeat, but then we obviously cannot replicate everything. The answer for this would be option number D, considering that when you move to the extreme right hand side of the curve, it is where the PO2 is super elevated, but the perfusion part in the lungs is down in the dumps because of a massive pulmonary embolism. Okay, so moving to the second one, which was regarding the length tension relationship of a sarcomere, and there was a line diagram like this where you had to basically correspond to the max tension that is generated in the sarcomere with the four diagrams that are shown here. And between A and D, which I think you can see that there is overlapping between actin and actin, that will not generate power. It is the actin and the myosin interaction which would be basically required. So the correct answer in this question would again be option number D. It's the actin and the myosin interaction which we need to consider. So I'm going stepwise. First, I'm focusing on physiology, anatomy, biochemistry, and subsequently like that. Then we have a question on a patient who went for trekking high altitude. That's a piece of cake. I think there would be hyperventilation. There would be carbon dioxide washout from the body. And every time like carbon dioxide washout contributes to respiratory alkalosis. Then was a question on high altitude cerebral edema. There can be two possibilities. I mean, if it is high altitude pulmonary edema, then there is a vasoconstriction, and that causes shear stress on the capillaries, and that's why like the person can have a breathing trouble. But when there is going to be a vasodilation in the brain, it's going to stretch the pain sensitive structure in the brain. You're aware the pain sensitive structure in the brain is the dura mater. So the stretching of the dura mater will contribute to development of headache in a patient, and also contributes to development of like cerebral edema component. So this would again be like low PO2 mediated vasodilation if it is going to be with respect to the high altitude cerebral edema component. Then was a question on mathematics, which was related to interstitial hydrostatic pressure. And do comment in the chat box if the values are same or not. Maybe you would have forgotten the values, so still you can have a look at it. And my logic to solve this question will only be that in the interstitial space, the pressure is always going to be negative. So if you look at the options here, everything was positive, one value was zero. Even if you don't get into those complex mathematics, no, like the net filtration pressure is the hydrostatic minus the oncotic pressure, and then you get into the mathematics domain behind it. But the logic is that simple interstitial hydrostatic pressure हमेशा ही negative होता है. So among the options which are present here, I am terrible with mathematics, so I would not been able to solve it very frankly in the actual paper. My nerves would have been too excitable to get into any math, so I would have used logic at that particular point of time, and therefore in this particular question the answer would be given as option number D. Okay. Then is regarding the production of insulin with respect to the blood sugar that is elevated. This curve was obviously not present. This is a curve that I've taken from a physiology textbook, which is just to tell you how does insulin correlate with the elevation of blood sugar in a patient. So you would initially be having is a spike, and then you would be having is a sustained production. So among the options which are given here, which were like very closely worded, the most appropriate option in this particular case would be initial rise. That's going to correspond to the postprandial spike of sugar, and then subsequently there would be a sustained elevation of insulin that would be present. If you go through the English version of the remaining options, they can be easily solved out. So this would be option number D again. And then I have a question on a child with multiple fractures, petechiae, perifollicular hemorrhages, gum bleeds. So I'm thinking about scurvy in this particular case, and since I'm talking about vitamin C, so both lysyl and prolyl hydroxylase would be close options, but you know lysyl is related to mainly copper as a coenzyme related to minkase. So the answer in this case would be option number B, that is prolyl hydroxylase. Okay, then is a man who's trapped for 5 consecutive days. This actually happened, no? Like there was a soldier who was buried down for a fairly long duration. So his body would have basically used fat only, because like 5 days, that's huge, huge. You know, all the sugar part is gone, the gluconeogenesis part would not be functioning. So at that point, all that would come to, the saving grace would be the ketosis component. Then is a standard question that always comes on the topic of phenylketonuria, but like he mentioned the fact that phenyl hydroxylase levels are normal. So you are talking about like those variants that you talk about in phenylketonuria with respect to BH4, that is tetrahydrobiopterin, which would be responsible for this suboptimal performance of the enzyme, and that results in this elevated phenylalanine levels. Okay, so answer to this is option number B. We move to the next one, positive Romberg sign and neurological findings for B12 deficiency. And there are elevated homocysteine levels. I mean, somehow they always have this fancy for homocysteine, as I've said. So traditionally they ask about methylmalonic acid levels, but this time they ask about which amino acid would be deficient in these patients. So you guys can do a commenting here, guys. Yes, guys, hit the comment button. Let's see, like you guys have been silent for a while. So that will give me an opportunity for me to actually just see if you just want to comment. Whatever you feel like, guys, hit the comment button, and that would I think increase our participation as well. Yes, I think that would be methionine. That would be the correct answer in this case. Great. Fine. We move to the next one, hydrochlorothiazide with features of neuropathy, heart failure, and symmetrical tingling. Very honestly speaking, I mean, the way to solve this question, like somebody to be aware that hydrochlorothiazide will contribute to thiamine deficiency is a far-fetched. But there was mention of heart being involved, and then there was involvement of the nervous system. So when we have heart involvement and a nervous system involvement, then the vitamin that we're thinking in terms of is a thiamine. So if you can solve it from hydrochlorothiazide aspect, I mean, I am okay with it. Otherwise, like the heart and the nerves part should do a trick for this question. Then is a question with respect to insertion of a new nucleotide at the fourth position in mRNA sequence with 900 nucleotides. That's gonna interrupt the entire process, and therefore the protein that would be formed would be affected. The answer in this case would be option number C. As I've said, like this is not a session for those who would be like maybe planning to sit for an exam. This is for those who have actually sat for the exam, so that they can just do a post-mass analysis. Okay. Then is that orange color tonsils. We had one consultant who used to, always ask in every case whether you examined throat. And the story was like he always used to say, did you check tonsils of a patient? And like for a case like abdominal case, we never used to check, oropharynx, and we used to get a scolding that why did you not check for orange color tonsils? That would be for Tangiers disease. So I remember it from my consultant's scoldings that I had, that orange color tonsils are seen with Tangiers disease, and the remaining biochemistry aspects are very much there. Okay, then is familiar hypercholesterolemia. In FMG exam, they asked about type 3. That was in the FMG exam, but in the NEET PG exam, I think they were using the same kind of a database only. This was easy subcutaneous xanthomas. The cholesterol part was like elevated, LDL was super elevated, but triglycerides were normal. So that differentiates between 2A and 2B, and you can work out the final answer to this particular question as option number 2, option number B, that would be 2A by Fredrickson classification of hypertriglyceridemia. Okay, fine. Moving to the next one, then we have this patient who's having freckles, marked photosensitivity, and basal cell carcinoma by aggravated by sunlight exposure. That would be xeroderma pigmentosum. And yes, guys, hit the comment button with respect to xeroderma pigmentosum. I think that's an easy one, a straightforward fact-based question that again I think you all are familiar with. Yes, guys. Yeah, exactly. Nucleotide excision repair would be the correct one. I think in FMG exam, the question was on mismatch repair. It was asked with respect to hereditary non-polyposis colonic cancer. So the database is effectively the same. It is just that, I mean, they have the entire database or set in front of them and they randomly select questions. But the disadvantage for you guys is that there is obviously a big time negative marking present. That's like a Damocles sword sitting on your head. And I think that is what would be the main thing. I mean, it always has been, right? For I can say for months and for years and for like since ever since these competitive exams have come in, one thing that is always bothering the students is the negative marking that tends to pull down the score. So I agree that there would be a couple of negative scores or there would be some silly mistakes, but then everybody makes it. So sometime I think that overall normalization process would come in, and if you get one wrong, then maybe another person is getting another one wrong. So it just boils down to was it your day or not, and it's a wrong way to actually analyze somebody because 3 hours में हम किसी को analyze कर रहे हैं, that is like a little 3.5 hours is a little, I would say, very tough competition in our country. Okay, then is yeah, Damocles sword is the most appropriate description that I can give for this. Then we have is a cherry red spot with neurodegeneration, hexoseminitis A. So I'm talking about Tay-Sachs disease, and whenever I talk about Tay-Sachs disease, this would be GM2 gangliosidosis. He asked about the category of lysosomal storage disorder, so it would be GM2 gangliosidosis. Then I think he himself mentioned the enzyme there also, that is idoronidase, and this would make the diagnosis as Hurler syndrome. And I think you guys are very good at Hurler versus Hunter like that. I mean, you are aware of all those core spaces and where do you get corneal opacities, but he did not even get into that. He was pure biochemistry about the products that would be accumulating there. That would be dermatan sulfate and heparin sulfate. So you guys keep on hitting the comment button. I mean, that would just keep on, I would say, fine tune your reflexes, or they like they say a warrior is always going to be practicing his art. So that's what you are doing at the moment. Like, I know that it's like all through the, when you finish that battle line, you are always like bahut ho gaya yaar, chhodna. But then I think that if you keep on practicing your art, it makes you better at everything that you do. Okay, then structure not passing through the foramen. So I think some people said it was foramen lacerum. Some people said that it was jugular foramen. If I go by jugular foramen, it is like 9, 10, 11. And what is not going to be traversing would be the 12th one. So it would be hypoglossal nerve. Then is a question on patent ductus arteriosus. There was a shunt that was connecting the aorta to the pulmonary artery. And since I initially thought that maybe the question would be some malformation related to the subclavian artery, but then it was simply a connection between aorta and the pulmonary artery or patent ductus arteriosus. And for this would be the left sixth aortic arch. The answer for this would be option number B. Yep. Okay. Then are two muscles. I'm not sure exactly these muscles were there, but yeah, there was a neck dissection. And if it is like, if you mark nerve to mylohyoid, I'm okay. If the muscle was mylohyoid, I'm okay with it. But I think it is the anterior and the posterior belly of the digastric that are mentioned there. And you can solve it on basis of embryology only. I mean, related to the posterior belly of the digastric, it would be related to the facial nerve, and the anterior belly would be related to the mandibular nerve. So in this case, if the marking is for the digastric muscle pool, otherwise, like if it was on the mylohyoid, I have absolutely no issues with that. I mean, you would have then marked it correct appropriately. There is a question on like there was, I think, a description saying old person coming with obese person coming with myalgia paresthetica, that is the lateral cutaneous nerve of the thigh. So what you can see here is the green part marked here, that is T12 and L1, that would be related to iliohypogastric and ilioinguinal. Then point number B marked is genitofemoral, and the nerve that we're talking about at the moment is the lateral cutaneous nerve of the thigh. That would be option number C in this case. And as far as option number D is concerned for this question, I'll mark it here. That would be the femoral nerve as well. So I think the only issue would have been because the part marked A was bifurcating into two. So that would have resulted in like a switch between B versus C, or the error that can be introduced, because you can see the green marking there and the yellow marking, and it may not have been so prominent in the actual image as well. Okay. Moving to the next patient, we had this patient who had a forceful eversion injury, and the structure that would be involved would be on the medial side, that is the deltoid ligament. The answer in this case would be option number C. And then the hint you can see is that fibular coming up, the odd man out, I can say, and that are related to the lateral part, lat supports in the lateral part of the foot, and the part medial is the one which would be affected in this eversion part. Okay, so if it is the same image, then cool. I mean, Great job for the team that they were able to pick up the correct options, pick up the correct image. Patient is working out in a gym, and during a gym, he is ending up with a tear in the triceps muscle. So he says, like, which anatomical site that the long head of the triceps originate. Um, okay, you guys can comment regarding the location, guys. Long head of the triceps. We have a lateral and a long head, right? It's the infraglenoid tubercle, which would be the one from where the avulsion part would be occurring. Yes. Question number one on the agenda at the moment would be a intraoperative picture. This probably was an intraoperative picture. Here, I would just like to say that if it is a surgeon who would be, asking or framing a question like this, then he'll be putting up a question with respect to damage to the marginal mandibular nerve, because damage to the marginal mandibular nerve during submandibular gland surgery can result in paralysis of the lower lip of the patient. So they have to be concerned about it. If the question mentions deep to the submandibular gland, then the answer would be given as hypoglossal nerve. So if I go from the surgical perspective that there was an interoperative picture, then we'll talk about like the marginal mandibular nerve. But don't worry, like if you marked it as hypoglossal, I'm okay with it, because the dissection part will decide. If we are talking about the deeper structure which is deeper to the submandibular gland, it will be hypoglossal only. But a more logical sense is like they'll, if they're giving like a if they're giving a cadaveric image, then I think that they might be giving you hypoglossal nerve. But if it's a surgical image that is given to you, then for a surgical image with respect to submandibular gland surgery being done, then I think if it's a surgeon who's framing a question, he would first think in terms of like what nerve can be injured during the procedure, and therefore it will go in favor of marginal mandibular nerve. So any of the two can be answers depending on the perspectives in this particular case. And yeah, I mean, if he mentions facial artery would be pretty far away from the site that I mentioned. So labial artery is a branch of facial or related to the facial only, no? So like I can say like that. But then it's the nerve structures that I would like to focus upon, because they are the ones which can be injured during surgery. Then is that intern being quizzed by a junior resident or a senior resident regarding the components of the umbilical cord, so two arteries and one vein. And yeah, if the gland is flapped up, deep structure, I agree to you, doctor. I 100% adhere to what you said. My perspective is only if it's a surgical image superficial to the gland, then medial marginal mandibular. But if it is going to be structure much more deeper, then yep, I mean, passing between the two big muscles, then it is the hypoglossal nerve as an answer. So I think you did correct in the question. It's just my opinion, which I wanted to just share here. Okay, deep is hypoglossal, doctor. I 100% agree to whatever you're saying. Okay, then is that umbrella cells for ureter. This is like the standard transitional epithelium that we always talk about. And answer to this is option number A. And then comes your favorite question on faggot cells. Lots of oil rods, patient came with bleeding manifestations. So we're thinking in terms of M3 variety of acute myeloid leukemia. And for the acute promyelocytic leukemia, I mean, the chromosomal translocation would be 1517. That would be PML rara. Yeah. I mean, the faggot cells part is substandard. I mean, I've always said that hemat is something which is like if you do good enough from pathology, then the medicine part, just if you can spend 1 hour on the treatment part for all of them, that is more than sufficient. Okay, then is a question that had classical terms centrocytes and centroblasts, and then with BCL2 positivity and CD10 expression. And this would be follicular lymphoma, considering BCL2 positivity and CD10. I did have some people mentioning regarding cycling DN1 and SOX1 as well, but I think if it was, then you would have got it correct for mantle cell lymphoma. But the way it is framed at the moment, we'll go with option number C, that is a 14:18 translocation for that follicular lymphoma, the way it is framed. Another possibility would be because oil rods, no, because DIC is related to, and I mean, one is the highest concentration of oil rods are found in M2 and M3 variety, na? And the bleeding manifestations are again a feature that are related to DIC, na? Acute promyelocytic leukemia would be related to bleeding manifestations, that is DIC. That is one possibility. And another aspect I can say is that anyway, there can be thrombocytopenia, which is a direct implication even of any blood cancer, because it will infiltrate the bone marrow, and therefore, like if the myeloid cells, myeloblast is proliferating, the megakaryoblast, the biggest cell in the bone marrow, will not have space to multiply, and therefore the platelet count is bound to decrease. Then is that imperative question on Marfan syndrome that is always asked, that is like FMG repeat question that came up. The next one talks about the testicular mass in an individual. So we are always worrying about that seminoma versus non-seminomas. And then he himself mentioned regarding this well-circumscribed homogeneous mass, non-hemorrhagic, fried-like appearance, large polygonal cells present that help us identify that this would be a seminoma. This is a repeat which has come multiple times because this is one of the commonest testicular tumors. So that is why like maybe he likes to ask about it. Okay. The next question is regarding visual disturbances and a delayed growth with a suprasellar mass. Maybe the visual disturbance was described in the form of bitemporal hemianopia. Even if not, if I talk about a suprasellar mass given in a question of a child, I mean, every time I read about a child with a suprasellar mass, the first thing that comes to mind is a Rathke-Spauld's derivative. That would be that's going to be craniopharyngioma. Now, why it is not a Rathke cyst is one, the epithelium is different, and then there was that keyword which was given here, that is wet keratin. And what I mean by wet keratin is that there are various, there are two varieties of craniopharyngioma. So the Adamanitomus variety is associated with wet keratin deposition. That would be wet keratin, that loose eosinophilic keratin nodules present. So it is only with respect to a subtype of craniopharyngioma that is trying to put up that information of wet keratin, and therefore like the Rathke-Spauld's derivative craniopharyngioma would be an answer here. Maybe one option was Rathke-Spauld's, second was Rathke cyst. So I mean the epithelium of Rathke cyst, the though it can also develop in the same area of the adenohypophysis, that is the anterior pituitary, but then considering the word suprasellar mass, child, and then wet keratin written, everything goes in favor of craniopharyngioma in this particular case. Medulloblastoma, if I pick up a comment, guys, that is infratentorial. Now, so medulloblastoma is infratentorial tumor, so the manifestations would be grossly different. Then is the only condition where we have a anemia with high MCHC, that is a mean cell hemoglobin concentration, is hereditary spherocytosis, where we go for elective splenectomy in a patient. So the answer to this would be option number B. Then is the quantifying the cluster of differentiation markers is flow cytometry. So this was more like a general knowledge evaluation. So there were like some which had to be literally hit out of the park. The question then talked about a chap who's having this mass in the front of the neck with what a painful swallowing dyspnea. And then the histopathology was for synaptophysin chromogranin, and like the keyword was amyloid deposition. I mean, in my opinion, like if I was given a question like this and I'm thinking about a thyroid mass, I would be hunting for this word amyloid deposition, which tells me it's a medullary carcinoma thyroid. And then from your pathology knowledge also, you're aware with respect to chromogranin and synaptophysin helping in the diagnosis of this case as MCT as well. And the MCT is like one of the most aggressive thyroid cancers. It is multifocal, it can be bilaterally present, and that makes it super aggressive. And is also associated with multiple endocrine neoplasia as well. So that is why, yeah, one option can be undifferentiated. Yes, doc, I can put it there. The undifferentiated variety is another option that I did come across. I put up anaplastic carcinoma. Okay, the answer for this would be option number C. Then we have a patient with joint pain and then positively birefringent. Standard information whenever we read about negative birefringence, it's uric acid. Positive birefringence would be pseudo gout, and there was no mention of any knee. You know, if he mentioned the word knee pain joint, then you guys would have corrected immediately. So probably he was trying to look for evidence of any in that positive birefringence thing. Then is a question on scleroderma where he says like which is strongly associated with. So like there are only two options which are to Raynaud's phenomenon can be seen in SLE also, so it can be ruled out. GAVE is a real thing. I mean it causes an upper GI bleeding. But in calcinosis cutis, which is a feature of Crest syndrome, it is interstitial lung disease, which would be relatively a more common association. I mean, that's one of the reasons why these patients will tend to deteriorate, and one of the reasons why these patients die also. I mean, one of the logic I can say is from the medicine perspective, like how do you solve this question? Is I've said one of the main reasons why patients with scleroderma die is because of lung disease and pulmonary artery hypertension. So, I mean, if you remember the statement, like SLE patients have a kidney involvement and they die, and here it is. And another reason is exerted atherosclerosis for SLE. In scleroderma side, the leading cause of death is pulmonary artery hypertension and interstitial lung disease. Then is this question of gluten sensitivity. This is an FMG exam question, and then you can see those focal deposits of immunoglobulin A which are present. There is mention of those itchy vesicular lesions. So everything is pointing towards DH, that is dermatitis herpetiformis. The antibody that we get here is the anti-epidermal transglutaminase antibody. I mean, for the FMG guys, it was asked as which antibody is associated. Here he did not even bother to get into the antibody. He said like what is the diagnosis, that would be DH in this case. For the next question, patient is having dry cough, dyspnea, and a lymphadenopathy with granuloma with giant cells and stellate inclusions. Now, stellate inclusions would be that same asteroid bodies, and there are circular lamellated concretions which are present. So, considering that there is manifestation of dry cough, lymphadenopathy, hilar lymphadenopathy, biopsy has been done, because in tuberculosis most of the time it will not be a very significant hilar lymphadenopathy most of the time, and even if it is present, it's not going to contribute to significant stridor or dyspnea in a patient. So considering even if the age group is not given, we'll go by first definition. Diagnosis in this patient is sarcoidosis, and there was a lot of confusion with respect to whether the word was stellate granuloma. It was granuloma with stellate bodies, guys. I mean, instead of writing the word asteroid body, was stellate body लिख दिया ना, so it was not a stellate granuloma. I mean, one input that I got was it is a stellate granuloma. Stellate granuloma is like what you see with cat scratch disease. So I know that. So like it was not a stellate, it was a granuloma with stellate inclusions and circular laminated concretions. Then is a question on S-Sjogren syndrome, that is anti-Ro and anti-La antibodies, and that would be a lymphocytic infiltration and destruction of the salivary and the lacrimal glands in this particular case. Yeah, I agree. Stellate word was there, but it was stellate inclusions, doctor. It was not stellate granuloma. And even if he's saying that, I mean, the implication or how I will interpret this is going in favor of like massive alveolar lymphadenopathy as that of sarcoidosis only. Okay. Then is a question which had a lot of, I would say heartburn for everybody. So I'll try to give you two versions of this. So please hear me out. I'll take 2 minutes and listen to me. Patient is coming with pink frothy sputum, dyspnea, and paroxysmal nocturnal dyspnea, dies within 3 hours. Autopsy is showing hemosiderin-laden macrophages. Now I know this is a feature of left ventricle failure and is not a feature of right ventricle failure. So if the question is simply saying what is not a cause of heart failure cells, I'll answer this as right ventricle failure. But if he says which is least likely to occur with heart failure, then hear me out. One, I'm showing you a reference from Robbins. Robbins says that heart failure cells are a feature of previous episodes of pulmonary edema. This acute episode is like he is already a case of chronic heart failure, and chronic heart failure patient is now having decompensation and he went into acute decompensated congestive heart failure. But if the biopsy is showing presence of heart failure cells, it means that this particular patient was having a long-standing pulmonary edema. That is, long-standing LVF will cause RVF, no? Because most common cause of right ventricle failure is left ventricle failure. So LVF will cause right ventricle failure, and right ventricle failure is a known cause for development of protein losing enteropathy because it will cause a back pressure changes. That will cause a venous congestion. That venous congestion will translate into increase in the lymphatic pressure as well, and that can contribute to protein losing enteropathy as well. So if the question is talking about what is not going to be a consequence of this question, then it's going to be answered as protein. I mean, if you go by what is printed here, least likely to occur in this patient, I'll answer it as a protein losing enteropathy. But if he says least likely to cause it, if he says what is least likely to cause heart failure cells, simple pathology, ज़्यादा दिमाग लगाना ही नहीं है कि लेफ्ट है फिर राइट हो गया फिर प्रोटीन लूजिंग एंटेरोपैथी, इतना दिमाग लगाने की जरूरत ही नहीं है. If the question is simply like what is least likely to cause heart failure cells, right ventricle failure. बट इफ ही सेज कि विच ऑफ द फॉलोइंग इज, ये मिलता सब कुछ है. अगर एलवीएफ होगा तो आरवीएफ भी होगा, आरवीएफ होगा तो प्रोटीन यूजिंग एंटीरोपैथी भी होगी, लेकिन सबसे बाद में होगी ना, सबसे लास्ट में जाके होगी. सो देयर कैन बी टू वर्जन्स हियर. वन आई पुट अ बोल्ड फॉर बी टू से दैट डिपेंड्स ऑन द पर्सपेक्टिव. इफ ही सेज लाइक these can be two inputs in my opinion for the question, and because we had already a big chat about it, so I did not get into the actual chat that might be going in at this moment because we have already deliberated about the two versions of the question. So I mean, whichever you mark depending on the language of the question is a correct one in this particular case. Okay. Then is that CA125 that is super elevated in a patient, multiloculate ovarian tumor. So that would be epithelial tumor, and the epithelial tumor would be a serous cyst adenocarcinoma. I mean, that's the commonest ovarian tumor that we see at any time. The answer in this case would turn out to be option number D. Then is a question where he mentioned regarding a tumor at the cerebellopontine angle. And the history also mentioned regarding a hearing loss in a patient. So if I combine the two, a tumor at a cerebellopontine angle and a unilateral hearing loss, tinnitus, unsteadiness, gait imbalance occurring, and multiple cranial nerves subsequently can be involved, then even if I don't get into that Antony A and Antony B, I still can figure out the answer in this question as schwannoma. The answer for the current question on the screen would be option number A. Okay. Then is a patient who underwent a cesarean section. What a drug would be recommended to prevent a postpartum venous thromboembolism? Here, my point is immediately. What will you give to the patient immediately after delivery? So we will be giving heparin to the patient. I agree to the fact that warfarin will also be given, but on a long-term basis. But immediately, first thing that would be given in the immediate postpartum period for the management would be low molecular weight heparin. So there were two close things: low molecular weight heparin and warfarin, both as well for the preventive part, but then it is like low molecular weight heparin that would be required. Then is a lady who's diagnosed with migraine as a family history of CAD, and she herself had chest pain while giving sumatriptan. I had a chat with students, like there was no mention about lasmiditan being given in the question. And anyway, the question is now talking about not acute management but for prophylaxis. Then my only point is, if it's a 26-year lady, because migraine is common in young patients now. So in a woman, if you're planning to give topiramate for prophylaxis, it would be a big risk in that particular circumstances, because it's a teratogenic molecule. So we'll go by propranolol. I agree to the fact that propranolol can contribute to increase in lipid profile, derangement of lipid profile, but it's gonna be good for patients if they're having a heart disease present. Here, the correct answer in this question is option number A. I know that couple of guys are saying topiramate. My only point of counter is that topiramate, like, the topiramate is a drug that can contribute to neural tube defect. So if you're prescribing it to anybody, whatever, whether it is for epilepsy, whether it is for prophylaxis for migraine, you have to be very sure that patient is using proper contraception and there is no risk of any pregnancy, because otherwise we'll end up in a soup and a medical legal issues in those circumstances. So at the moment, like, this would be okay, so great. Only 8 are wrong out of 26. So great, man. I mean, great going, and just continue. I have 191 in front of you, and I'll not take too much of time. So the next one is about tumor lysis syndrome, and there is like elevated uric acid levels. Pagloticase mechanism is being asked in this particular case. So we are gonna be destroying that into allantoin, and that's gonna be oxidizing uric acid. Then is your favorite. I mean, they always talk about bindas drugs, that is like beryllium, and then ibutylide, and then amiodarone. So I think amiodarone came up this time among the bindas drugs. I mean, it will act on which phase? So it would be phase 3, that's related to potassium channels, and therefore there would be like a prolongation in this particular case. Okay. And I think there was a very clear-cut mention also in this question. Like, there was a very clear-cut mention with respect to the various uh, sodium entry, potassium entry, like that. It was a complete description that was given in a question. So I think that would also help you out in coming to the final answer for this question. Okay, then is a patient of GRD, and he says what is going to increase the tone of LES and promote the gastric emptying? That would be metoclopramide. I mean, a prokinetic agent is what he's simply asking, because alone with pantoprazole, we may not be having is a very good result. For the next question, I know there will be a slight controversy. I'll give you reference for the same. A patient presents with burning sensation on eating spicy food, and there are like these lichenoid lesions that are present in the oral cavity. So there are two close answers in this case. One is going to be lithium and second is going to be beta blocker. And I think that multiple people have told you lithium, multiple people have told you beta blocker. I will give you reference of Harrison. Please check out the reference here. This is what Harrison says, that lichenoid eruptions would be with the following group of drugs, that is thiazide, antimalarial, quinidine, and beta blockers. And beta blockers are more commonly prescribed as compared to lithium. I had a chat with the dermatologist as well regarding the same also, and I mean, the person that I spoke to, they were of opinion that beta blockers should be given as the single best answer here. So, and because they're much more commonly used as well. So in this circumstances, like the correct answer, in my opinion, would be given as beta blocker. And if it was I was you, then I would have considered it as one of my bad luck on that day in case I mean, whether I was able to score it or not, because I would not have very frankly read this very well. But that for the oral lichenoid lesions, this is a reference from Harrison. You can take a snapshot of it if you want, check it out by yourself also. And there is no mention of lithium in that. So if you can find a reference for lithium, I mean, do ping me up on my Telegram group, and I'll be like, very happy to receive a reference from you. I mean, we go by textbook references, as I can say, and obviously not chat GPT or anywhere else. Okay, so this scheme starts at about 8 p.m. today, and you can just check that out. The next question, again, these three set of questions, I've kept them together because there were conflicting inputs with respect to them. Patient is having palpitations, headache, diaphoresis, standard PhD for a pheochromocytoma with increased metanephrine levels, and what drug would be used for pre-operative as well as intraoperative management? If the question was simply for pre-operative, then the answer is given as phenoxybenzamine, never an issue. But if the question was mentioning can be given intraoperatively as well, then we cannot give phenoxybenzamine because it is long-acting during surgery, because it will cause a post-operative hypotension in a patient, which is always a big concern in all patients undergoing a pheochromocytoma surgery, because anytime all anesthetic drugs are vasodilators, and if I give phenoxybenzamine at the time of surgery, then post-operative hypotension will be accentuated. But all anesthetic drugs are said vasodilation, and phenoxybenzamine anyway, it will control the paroxysmal spike, that is okay, but then it can cause a post-operative hypotension. So in those circumstances, like, the answer should be given as, if it is intraoperative given in a question, as labetalol, alpha plus beta, both would be controlled in this particular case. Otherwise, from the options which are given, if we just focused on pre-operatively, guys, then the answer is given as phenoxybenzamine. I'll repeat my statement once again. If the question focused just pre-operative, never an issue. I mean, standard data, phenoxybenzamine, we move ahead. If he says also used intraoperatively, then the answer is a big no. We cannot give phenoxybenzamine. It can cause a post-operative hypotension, and then it would be labetalol, alpha plus beta, that would be used. So I hope I can give my rationale in this particular case. I mean, everything is based on rationale only, guys. Everything is based on logic or on rationale only. Okay. Moving to HIV positive patient with rifampicin resistant. So BPAM they had to ask about BPAM anyway, and then we have to monitor for immune reconstitution syndrome IRIS, because anytime we are treating any patient of immunocompromised state, then there can be a paradoxical worsening of symptoms as well. Then we move on to a patient who's having this perianal itching, Scotch test, plano-convex X present. That makes the answer as enterobius vermicularis. I could have solved this question only by that one word, Scotch tape test. I think that's all what he wanted to ask, Scotch tape test, because the worm comes out of the anus at night, causes perianal pruritus, cries a lot, cries a lot at night. So enterobius vermicularis. Okay. Then is a sewage worker who died due to femur jaundice and conjunctival hemorrhage. So what we're talking about in this case is one, a hepato decompensation, and because the liver is decompensated, therefore bleeding will also occur in this patient, and this guy can then have a multi-organ failure. He can end up with even a kidney failure subsequently, though he has mentioned only about fever, jaundice and conjunctival hemorrhage, because liver is the source of all the clotting factors, and a sewage worker, I'll think in terms of leptospirosis, that would be Weil's disease. And when it comes to brucellosis would be with respect to consumption of non-pasteurized milk, and there would be fever and organomegaly, but there would be no jaundice and a conjunctival hemorrhage that is present. I mean, this is where the liver is getting damaged. So one possibility initially I thought was this guy could be having is a viral hepatitis also, but then he did not specify regarding the type of viral hepatitis that is present. And then most of the time viral hepatitis, all cases don't result in death. I mean, among the two diseases, which is more lethal and causes death, then leptospirosis has more chances to death. Viral hepatitis A and E तो होता रहता है हमारे देश में. अभी जैसे it's gonna be raining and the sewage and the sludge water will mix with drinking water and golgappe वाला पानी, and people will be eating that and end up with viral hepatitis. So do hit me up with the options, man. Do hit me up with the options. I've done already a lot of hard work into that pre and intraoperative part to be found out. So hit me up with the options, and whether just a vague comment like this is not there, that does not suffice the job. Okay. We have this low immunity patient, and then there is that bowel sample that was taken, and there's septate hyphae with dichotomous branching, that acute angle branching that you can see, that makes the diagnosis in this patient as aspergillus in an immunocompromised patient. Okay, moving to the next one, we have this patient who is having fever, cough, and weight loss. So initially I thought he's asking about TB only, but then the images, this either of the two may be present or none of them could be present. But he mentioned the word narrow-based budding. That budding B word is for that. I mean, you can comment on the answer for this one. Yes, guys. Yes, histoplasmosis in this case for the narrow-based budding. Then his question on filariasis, he did not even ask about those various subtypes of Wucheria bancrofti and the other variants. Rather, did not ask about where is the terminal, I mean the terminal appearance of the tail, but it is rather a question, why do you get a development of a lymphedema? That lymphedema will be due to the obstruction of the lymphatics. That is what we call as elephant foot. Then we have a patient with brain abscess. This alone is sufficient to crack the question, because most common cause of brain abscess is anaerobic organisms, and he is himself mentioning gram-positive filamentous bacteria, and then everything that is given here, that it is strong, it is like mildly acid, fast, it has AF, it's positively staining for acid fastness and paraffin bed technique. So weakly acid fast, as you said very correctly, that would be going in favor as nocardia. And usually they give teach us two slides always which are acid fast. One is to differentiate the nocardia slide from that of tuberculosis. So I think here we did not even have to get into any slide. It is just that the availability of that's a good slogan, है ना, आपकी बार 200 पार. So anaerobic brain abscess is what we're talking about here. Then is syndromic diagnosis of meningitis, because there are so many bacteria which are causing meningitis. So we have to go for a PCR, and the PCR that can test for everything would be multiplex. You know, like in multiplex, you have multiple movies being screened simultaneously. Similarly, and nested will be for specific isolation. Like you are able to isolate one, you want to improve the diagnostic sensitivity and the specificity, then it is a nested PCR. But if you want to go for like a syndromic approach, then it would be a multiplex PCR. Then another question of meningitis, very interesting one, was that patient was brought in with hypotension, and then there was petechial hemorrhages that were given along with brain hemorrhage. You know, I mean, maybe that specimen was given or maybe not given, but if I'm having a meningitis history and hypotension, then I'm talking about Waterhouse Fridson syndrome. I mean, this is gonna be classical Addisonian crisis that is asked or is usually described. And I think even on this also there were two questions. One was on the prophylaxis part. What antimicrobial will be given for prophylaxis? There was no fluoroquinolones, rifampicin, and meningococcus is anyway, I mean, notorious for contributing to mortality. The correct answer for this would be option number A. Okay, then is another question of meningitis. This was recurrent episodes of meningitis, again with meningococcus. Now, even if that is not mentioned, we know that MSC, membrane attack complex, is if it is affected, then it contributes to recurrent episodes of meningococcal meningitis. So the correct answer for this would be option number B. State quota. Doc, at the moment, my mind is too occupied with solving these. So sure, I like to comment on this at the end. At the moment, please let me focus on the quick academics part. Okay. Then we have a patient who is having a severe abdominal pain, and the diarrhea which is present in the patient is rice water like, and there's a garlicky odor that is present with respect to the poisoning. So everything goes in favor of one of the commonest homicidal poisoning. I think I don't need to mention that manifestations also of acute arsenic poisoning or got into the technical details of it. This would be option number A. No, guys, it was not an easy one. They were tricky ones, like I'm describing once before you. Okay. Then were two questions where answers were 18 years, and I had a chat with the forensic person so that I could come to the information here. One was a non-consensual sexual act between like a teenage girl and a guy who was 23 years of age. So the consent is not valid because the patient's age is under 18 years. And then was like the most Googled thing after like the sudden traffic of Google would have increased with respect to POSCO, and that's gonna be like option number A. So great, guys. I think two questions on 18, I mean, underage related aspects which are to be answered. Then is Zasco's phenomenon. I mean, normally we talk about deep tendon reflexes, but this is like a googly to me. Honestly, I wasn't aware of this, so I had to actually search about it. Zasco's phenomenon would be a tendon reflex that would be occurring after death in a patient. The answer would be option number A. 70th, I was like very confident about this. I have already because I have seen cases like these where patient came with a head injury, CT scan was normal, and patient we were almost on the verge of sending him home, and my consultant said, my senior resident said, no, don't send him home, he could be having a DAI. And I was like, what is DAI? So he said, padke aana. So I read about it at that point of time, that any patient who's seemingly normal after a head injury, don't send him back home immediately. He can die because not only because of the lucid interval thing, but it can be a diffuse axonal injury, like in this patient who had these bleeds in the corpus callosum. So that would be a diffuse axonal injury, or DAI, that would be responsible and has been well discussed multiple times. Okay, Ashu, we'll still go by Neisseria gonorrhoeae for the first, for membrane attack complex defect. Okay, next is a guy who's having this delusions of persecution and psychotic features at the time of the act. At the time of the act, he's saying that he's I mean, everybody who's committed any kind of a crime, as per the recent examples in couple of months, you see those people getting killed, wife killing husband, husband killing wife, and stuff like that. So a lot of these people might be, with help of their lawyers, staking a claim to insanity. So in this particular case, the next step would be refer for a psychiatric evaluation. I think like as a doctor to declare him not guilty would be, I think it's for the court of law to decide whether he's guilty or not. I mean, that statement, no, declare him not guilty and release immediately. I think it's not under our jurisdiction. So if this is a guy who's like saying that he's not guilty by insanity, we have to send him over for a psychiatric evaluation and decide that whether he's fit for trial. Okay. Then is another question which I checked up in Harrison actually, because they mentioned regarding palliative medicine. We have an old man who has been diagnosed with cancer. He is very anxious at the moment, and we have told him that I mean there is no treatment available because the cancer is spread, and the doctor is saying no, no, please keep my father in intensive care unit. I'm ready to pay whatever money you want, and we will not discharge the patient directly from a hospital with a cancer diagnosis like that. I mean, it is not discharge the patient and shift to the home-based palliative care. We first have to inform, like he's visibly anxious. If you read about the Mental Health Act also, he says that any patient who's diagnosed with a terminal illness, first you have to explain to the patient regarding the pros and cons of treatment, take into consideration his point of view. It is not the daughter's point of view here. It is daughter who's insisting on whatever, like she says, no, no, take all my money and be, please save my dad. And, this is the emotional outburst that anybody would be, saying whenever they are faced with such a kind of a dilemma. But it's not the daughter's counseling that we have to do, it's the patient's counseling that we have to do. So I'm going against what most people might have given as an answer to this one, that is convene a family meeting, consider the patient values and preferences. I do have a reference from Harrison as well, the palliative medicine chapter right in the beginning, which talks about patient communication and bad news. Like, I'm not talking about spikes. What I'm saying is bad news with respect to the various permutation combinations or treatment that we would be having for this particular patient. So the correct answer in this case would be option number A, and it would not be a hospice treatment. Okay, then a couple of them from PSM where I marked the answers already, because this I think you guys are anyway aware of. I don't need to give any inputs regarding it. The passive surveillance for COVID-19, the de facto for that वो घर पे जो आते हैं ना census का data लेने के लिए, and then is that alum and lime for the water purification part, and randomized control trial where we will assess the data at the end of everything. So these answers I've already marked because I think these have already been discussed. Okay. Okay, thank you, Nikki. Thank you for the input. Like, because in my group there was this discussion with respect to send the patient back to hospice. So I thought I should just justify my answer. Okay. Moving to 78, a bit of mathematics here for a 70 lakh population. Like, you have to calculate the urban primary health center. So the mathematics is in front of you, and I am bad at that. Then is that FMG question that was repeated here. So there were, I think, 3 or 4 FMG questions that were repeated. One was that Fugu question, patient went 100 kilometer away. I discussed it just 1 or 2 days before the actual exam. So like 3 or 4 questions were line to line repeat. This is another one that came up, unpaid P-test for unrated groups that we are evaluating in this particular case. Then we have okay, yeah, I mean, let's not get into politics here. Then we have this woman who has been diagnosed with HIV and started on antiretroviral therapy. The viral load is more than 1000 as a threshold, so we will have to, and it's more than 32 weeks also. So what we need to do is use 2 drugs at the moment. Normally we read about nevirapine only, but in this case, because of the high viral load and 34 weeks here, we have to just double our offense, and therefore it's nevirapine zutidine for 12 weeks with exclusive breastfeeding. Then this I honestly don't know and have never been able to remember, but you guys would be doing it better. Anopheles, Culex, Aedes, and Mansonia, how their larvas would be looking like, but I have marked the answer already. Okay. Again, a question on multiple programs, right? It was vitamin D, then nutritional deficiencies. So it is integrated child development scheme. Then is that Anemia Book Bharat. Here also, I think there was some issues, whether it's the old program or the new program, because the older program was, I think, 100 milligram, and the Anemia Book Bharat current program is 60 milligrams of elemental iron. The folic acid amount remains the same. But according to the information that I have received, is there is like the standard guidelines, the current ones that are mentioned at the moment. Okay. Then is evaluation. That is what we are doing at the moment. We are analyzing like whatever went wrong or whatever went ahead. But yeah, it's a good thing and a good exercise to do at this moment, because this would help you to plan things ahead for like even a forthcoming INI-CET as well. Then is a question on community health intervention where like 20 centers, there was allocation that was occurring and randomization. Randomly, the centers were selected because the word intervention is written. I think like cross-sectional case control, they all go back to the data. But at the moment, we're talking about a prospective intervention. So it has to be C versus D. With randomization occurring, it would be option number D. Then time interval between acquiring an infection and max infectivity would be generation time. So all those tables that you study, serial interval, difference between two primary index cases, all that information you are already familiar with. Vaxil vial monitor is again an easy pickup. There would be like the darkening part or the colors becoming equal would mean that you would not be able to use it. Then was a question of lead time bias. This would mean that if you make an early diagnosis of any condition, the mortality rate would go down. If the diagnosis is made later, then the mortality rate will increase. That's what I mean by the term lead time bias. देन अ फेवरेट दे ऑलवेज लव टू आस्क इट कि पहले क्या देंगे, पहले एटीटी देंगे, पहले एंटी रेट्रोवायरल थेरेपी देंगे, कितना गैप होगा, अगर उल्टा कर दिया तो क्या हो जाएगा. सो देयर हैव बीन टू क्वेश्चंस ऑन दिस. आई मीन ऑलमोस्ट एनीबडी who's talked about HIV, whether in pharmacology, whether in pathology, whether it is I have described, everybody I think they would have talked about iris. So I think these were easy picks. There is a question from ENT regarding recurrent epistaxis in a patient, and there is a nasal obstruction in the past 1 year. And then there's a bowing of the posterior wall of the maxillary sinus. That's the clear-cut distinction. 20-year-old male with a juvenile nasopharyngeal angiofibroma would be the answer in this case. Okay. 72-year-old smoker with hoarseness and difficulty in swallowing, and there's a cancer which is infiltrating down to the vocal cords in this case. I think it was turning out to be T3, and considering T3, the best option is a chemoradiation. Now, if that is not in the options, then we have to go for surgery. Agree to the fact that if it's gonna be compromising the trachea, we might have to plan a tracheostomy. But like I think that the gist of the question was like, what is the surgery that would be required in this particular case where the tumor is not amenable to radiation therapy? Because he himself mentioned like, the chemo radiation part is not okay. So the surgery that can be done in this case. Oh yeah, I mean, a lot of us operate on instinct also, so that's perfectly fine. I mean, I think most of us operate on instinct only. Okay, so in this particular case, guys, the best approach that we'll be using in this case would be a laryngectomy. The answer for this would be option number B. Hit me up in the comment button with respect to like the comments went down a bit. So if you can just comment there your answers also. Like I said, this is just a match practice that we're doing at the moment. Match analysis, in fact, I can say at the moment. Okay, fine. Then was, I think, a very funny question regarding, I think everything was given there. Airborne gap, and then he's talking about a perforation in the tympanic membrane. So if he's himself mentioning regarding perforation in the tympanic membrane, airborne gap, I know that we are talking about a conductive hearing loss in that question only. So that I would say like the 90th one and the 92nd one that I discussed were like relatively much more simpler and straightforward ones to analyze. Fine, I think we can move ahead in our discussion. This is a patient who is having again a perforation in the tympanic membrane. There is a hearing loss described in a question, and he says, what would you be doing in this case? They were like laryngoplasty and then exploratory tympanotomy that was given in the options, not tympanoplasty. So if these are the options which are given and there is no mention of any cholesteatoma, then we have to answer this as option number C. But if there's a cholesteatoma that is described in the question, then it is a modified radical mastodectomy. So I think there was an image that was given, and based on the image, we had to analyze the information. Then is a question on posterior epistaxis. There was no mention on the word posterior. It was just a hypertensive patient who was having a bleeding. So if it's a posterior epistaxis, the source of bleeding would be sphenopalatine artery. The answers would be in front of you. Yes, guys. Then is the ophthal one or white dandruff-like deposits on the anterior lens surface. Among all the options which are given here, glaucoma flecans, phacolytic glaucoma, I mean the only one which will be satisfying that dandruff-like lesions on the lens iris and the zonules would be pseudo-exfoliation syndrome. That would be related to open angle glaucoma. And the remaining options are like glaucoma flecans for angle closure, but then the description of those opacities would be grossly different. So I think it is between a glaucoma flecans and pseudo-exfoliation that you have to select. Yes, based on the image, if whatever is the, I mean, that for 94, I can say those images we cannot, I mean, non-retrievable, so though we have tried very hard to get them because there's so many differences of opinion. Okay, so intact ring would be for keratoconus. You can see that marking that looks like a metallic ring in the cornea, so that the keratoconus component can be treated. Then is a question that came in last time's FMG exam. There was an image of a girl with this swelling which is present on the lateral canthus. That's always going to be a dermoid cyst. It's going to be firm in consistency, non-tender, slowly progressive. So all the history that would be mentioned is related to that. Then is a question on guttate lesions in one eye, bullous keratopathy. Bullous keratopathy would mean that the endothelial layer of the cornea would be affected. And if I say the endothelial layer of the cornea is affected, then it would be Fuchs endothelial dystrophy. Question of binocular vision is anyway sorted. I mean, the image is self-explanatory, that dog versus human being, and then animal which is holding on to an object. So we can do SMP and fusion. SMP would mean a simultaneous perception. Okay, so this is a scheme that would be starting at 8 p.m. In case you would be interested, you can just go through it. Okay, so we are sorted at halfway mark. Let's do the remaining ones quickly as well. He says, what is true about orbital cellulitis? So it would be like anterior to the orbital septum is a close option, but we don't treat with topical antibiotics. And then there would be, I mean, normal people extraocular movements, like it's going to be painful. It's going to be horribly painful. So I can rule out two options here. And then anterior to the orbital septum, and then is ethmoidal sinusitis. So we'll have to go by a common cause in this case. That would be a orbital cellulitis. Yes, we need to prevent overthinking, I would say. I mean, I think the question was mainly because most of the questions were like based on overthinking is going to contribute, because we think that this cannot be a usual answer to a question. Okay, so a lady is having difficulty, वो आटा गूंदने में difficulty हो रही है, right hand motor weakness है, atrophy of the hand muscles है, so he's talking about a lower motor neuron lesion. I mean, everything else in the option is upper motor neuron, so the answer would be a right anterior horn cells in the spinal cord would get involved. Then is a question on fast correction of hyponatremia. This fast correction of hyponatremia will cause osmotic demyelination syndrome, so I need to do a MRI head because there's a quadriplegia developing in this individual. The next patient of mine is having an irregular pulse. That is what they took a fancy to this time. There were 4 questions on atrial fibrillation, and he says which of the following will not be seen. So if atrial fibrillation was not given in the question, then I would have said that the pre-systolic accentuation of the murmur is a hallmark feature. I mean, every time we read about a murmur of mitral stenosis, it will always start at the opening snap. It will peak in the middle, and then it will have a small secondary spike. But that small secondary spike will disappear if there is the atrial fibrillation present. So if this question is regarding primarily like what is not going to be present if there's an atrial fibrillation, that pre-systolic accentuation, this particular part of the spike will disappear because the atria is not contracting. The terminal part of the diastole is atrial systole. ये वाला जो part होता है, ये atrial systole होता है. The atrial systole is not happening, and that is why the atrial fibrillation part would come in. Then is a patient who's having again irregular pulse, and patient has come within 2 hours of management. Then for atrial fibrillation, the algorithm that I've described this before you is called as RACE. RACE is R is rate control, is anticoagulation, C is chemical cardioversion, E is electrical cardioversion. So first we need to go for rate control in a patient, and then subsequently the remaining things can be taken care of. It is like palpitations are the primary complaint in the patient, so that is why like rate control has to be used. For any patient of atrial fibrillation, guys, it is going to be atrial fibrillation. It is RACE as an algorithm. Rate control, anticoagulations, chemical cardioversion, electrical cardioversion is what I've explained. And cardioversion is out because there would be no hemodynamic instability. Then is a guy who's having features of stroke, and he's saying what would be done in this case. So one of the commonest causes for development of ischemic stroke in a patient is going to be atrial fibrillation. Like commonest variety of stroke is acute ischemic stroke. patient is having aphasia and right-sided arm weakness. So I'm thinking in terms of stroke. Commonest variety of stroke is acute ischemic stroke. And what is the most common cause of the commonest variety of stroke? Atrial fibrillation. So an atrial fibrillation will cause clot development of clots in the left atrial appendage. So if I'm gonna be having clots in the left atrial appendage, I'm gonna be going ahead with a transesophageal echocardiography in this particular case. Okay. Then is the prevention of PSVT. The question was not acute management. For the prevention part, we'll go for oral verapamil. As has been discussed, the first line treatment is the catheter ablation. And if catheter ablation is not there, then verapamil will be used. For any patient of ARDS, we have to go for low volume ventilation because of risk of barotrauma. So instead of taking a tidal volume at 12 ml per kilogram, we take it at 6 ml per kilogram. And the PEEP value has to be kept between 5 to 8 to ensure the recruitment of the alveoli. So the combinations here would be a low tidal volume and a high PEEP, which should be used for management of this patient of ARDS. IV RTPA would come up in the next question, doctor. Coming up very soon for that IV retapless question. Then is salt wasting, salt craving. That would be a feature of Addison's disease. There would be skin hyperpigmentation present. So anytime we read about like Addison disease, it's always going to be salt wasting as the key word, and the feedback mechanism will contribute to rise of ACTH. There was also a question on ACTH rise will cause pigmentation. That will come subsequently. Then we have a patient who's having a query diabetic ketoacidosis. Type 1 diabetes is described, though there is no mention of any ketonuria, there is no mention of any ABG report in a patient. He assumed it is DKA. And what will you not use in a patient? So that would be 3% saline. Everything else is done for management of this patient. Yeah, doctor, I think that would be okay. Ethmoidal sinusitis would be common across all age groups. Then is fluid causing hyperchloremic metabolic acidosis is normal saline, because normal saline is chloride, no? So negative charges in the body will rise. And if negative charges in the body will rise to maintain the electroneutrality, the kidney will cause bicarbonate loss. I repeat that statement again. If you give too much of normal saline to the patient, I posted this question multiple times and even my YouTube channel as a poll, and has been discussed also. Disadvantage of fluid says normal saline excess always contributes to negative charges in the body being more, and if the kidney will try to maintain electroneutrality, the kidney will cause a bicarbonate loss in the urine, and if you have bicarbonate loss in the urine, it will contribute to development of metabolic acidosis. So chloride in the blood is more and bicarbonate is being lost, so metabolic acidosis would be present. Yeah, I mean there was DNS also, but the concentration of saline, concentration of chloride in normal saline will be maximum as compared to dextrose, normal saline, and other fluids. Even if it is N by 2, N by 3, N by 4, N by 5, doesn't matter. The max concentration of chloride would be normal saline only. So metabolic acidosis is a side effect of, I mean ऐसे याद कर लो ना यार, metabolic alkalosis का fluid of choice normal saline होता है, क्यों? क्योंकि वो मेटाबॉलिक एसिडोसिस वाला कंपोनेंट क्रिएट कर रहा है, समझाने के लिए, राइट? कि मेटाबॉलिक एसिडोसिस का फ्लूइड ऑफ चॉइस रिंगर लैक्टेट होता है, मेटाबॉलिक एल्कोलोसिस में नहीं देते, एंड द फ्लूइड ऑफ चॉइस फॉर मेटाबॉलिक एल्कोलोसिस इज नॉर्मल saline. Then is a question on ankylosing spondylitis suspected. The X-ray is normal in a patient. So if you listen to the diagnostic criteria, it's hardly a 30-minute video. The mains one I'm talking about. Then you'll notice I've said MRI of the pelvis is the main test to be done for diagnosis of ankylosing spondylitis. Actually, B27 positivity does not help in that. Then is a question that somebody was pointing towards irregular pulse with stroke manifestations, and if patient is in the window period, I mean this patient is thrombolysis eligible, the patient is very much in the window period, there is no contraindication to thrombolysis. I asked a lot of people with respect to the blood pressure values. It was not given to be, at least even if BP value is not given in the question, okay. Some people said 160 by 100, but it has not to be more than 185 by 110. There has to be no evidence of any coagulopathy with INR more than 1.7. These are the two common or recent bleeding episodes. So none of the contraindications were given. So we can go in for a thrombolysis in this particular chap. There is a patient who's having morning stiffness and anti-CCP antibodies, which are diagnostic for rheumatoid arthritis. In rheumatoid arthritis, it is always a pannus formation. It was reactive, I mean, it was reactive lymphocyte infiltrate, reactive neutrophil infiltrate, and then is a pannus formation in this case. The correct answer in this is option number A. Then is hyperpigmentation, and this I already said that hyperpigmentation in Addison is related to ACTH. Patient of bronchial asthma is having nocturnal worsening of symptoms. He is on SABA plus SAMA. So for current treatment of asthma, we don't recommend a SABA and a SAMA. We recommend is a LABA with inhaled corticosteroids. So the next best step in management is just change the medication of this patient, start him on LABA, and you'll be through, because this is not recommended anymore. I mean, I got a B as an answer, doctor. I think I've explained it multiple times that salbutamol alone नहीं देते हैं, क्योंकि salbutamol देने से क्या होता है कि tachyphylaxis होता है, टॉलरेंस हो जाता है इन अ स्पैन ऑफ विद इन 5 days. आप देखोगे कि यूजुअली बाय 5 days वो पेशेंट ही बोलेगा कि सर अब ये दवाई का असर नहीं होता है. सो वी डू नॉट इंक्रीज salbutamol dosages. It's a rescue drug. It has to be respected as a rescue drug. It's not to be used to prevent an attack. Salbutamol is not to be given to prevent an attack. That is what I've highlighted multiple times. Then is a question on acquired. I mean, the word acquired was not given, that I've added from my description. The patient was having a disturbed coagulogram and was diagnosed with factor 9 deficiency. Factor 9 deficiency can be congenital, it can be acquired also. Normally, like factor 9 deficiency should not respond to vitamin K, but here it is responding because it is not congenital, it is an acquired deficiency, and that acquired deficiency is occurring because of the bile duct obstruction that is occurring in this case. So the correct answer in this question would be option number D. We don't give oral steroids, doctor, anywhere for management of asthma patients because of the increased side effects in a patient. But yes, you said a statement, so I'll just add it there. Oral steroids are a last resort that we've been using for like years and years altogether for management of our asthma patients. But like that would not be a very, I would say, good approach to use. There are two questions on ABG which were having this anion gap to be calculated. One, I think everybody was able to calculate this anion gap of value of 30. That would be like the mathematical data that I put up here. And apart from that, there is like all three values going down, down, down. pH is less, PCO2 is less, bicarbonate less. So that will make it a metabolic acidosis with the anion gap being increased in a patient. For my next question, listen to my words very carefully. I have a reference from Harrison for the same as well. The question says that for this particular type of chronic kidney disease, who can go into heart failure is found to have anemia, and anemia is the reason for development of heart failure in these patients. He says, what is the next step in the management? This question was repeated in the FMGE exam and came in NEET PG as well. If he says, what is the next step in the management? It is iron supplementation. It is not going to be answered as darbepoetin. If this question is asked as what is the best for management of this patient, if he says for best, then it is okay. Then for best, it is erythropoietin. But if it is next step in the management of this patient, I have a reference from Harrison. He says that you cannot start erythropoietin without depleting the iron stores in a patient, because a lot of these patients are having iron deficiency also. So we can start the patient on oral iron, or we can start the patient on intravenous iron, depending on whether patient is requiring dialysis or not. But at the moment, like if the question said what is the next step, then I'm okay with my answer, which I said is gonna be iron. And if it is going to be the best treatment, then it is erythropoietin. I think most of the references are coming for like, most of the messages that I got was like it was the best one, then it is okay. I mean, darbepoetin alpha. But then a couple of guys pointed, no, it was like what is the next to be done. At least in FMG exam, I'm very sure it was next step to be done. It was not the best treatment, because that's the twist in the question that can be put up there. So if it is best, it is cool. Otherwise, it would be answered. See, those misses will be hardly 5. Believe me, those misses, that's a plus and minuses that I'm saying. No, there would be maximum 5, maximum 6, not beyond that. So take those with a pinch of salt, and I can say that still you can get an approximate value of the score that you would be getting here. Then is a patient where pH is less and PCO2 is elevated, and that would be a respiratory acidosis in a patient. Now, between acute and chronic, I mean, some people said it was written or not. So I'll just go by this. If bicarbonate in the question is normal, then you will say that it is acute respiratory acidosis. If it is elevated, then we will say chronic respiratory acidosis. The logic is that 10:1 rule that comes in, like, if acute 10:1 and 10:2 rule. So if it is like the values are normal, slightly increased, then it is acute. But if it's a gross elevation, like you can see in this case, then we'll go by chronic respiratory acidosis. But if this question bicarbonate value is normal, it is acute. If it is elevated, it would be a chronic value. Okay, if it's a plain one, then respiratory acidosis is perfectly fine. The next question is regarding antimitochondrial antibody. Antimitochondrial antibody would be seen with respect to primary biliary cirrhosis. PBC would be the answer in that case. Then is a patient with coarse faces and large hands, and IGF-1 levels are like elevated. If IGF-1 levels would be elevated, that would be acromegaly. And then he says like, what is the best test to confirm the diagnosis in this case? So the test would be a glucose challenge test, and we will have a failure to suppress growth hormone by OGGT. It is not failure to suppress IGF-1. It is like failure to suppress failure to suppress growth hormone levels, which are in a pulsatile fashion. The values would remain subsequently elevated. Then was a very interesting question on hydrochlorothiazide contributing to renal stones in a patient. Well, the only plausible explanation is that it can contribute to a decreased urinary citrate. I mean, normally we give hydrochlorothiazide to those patients who are stone formers, who are stone formers, because they are gonna be like, having high calcium in their urine, and therefore we want to decrease the amount of calcium in the urine. But if the person is having stone, then another plausible explanation why he can develop a stone is due to stones also, no? Because thiazides can contribute to development of hyperuricemia. I mean, when you give thiazides, they cause hyperglycemia, hyperuricemia. So that can explain the development of stones or the decreased citrate in the patient as well. Okay. Next is a schizophrenia patient who is on haloperidol, and then there are like possible dystonia present. He says like, what is the likely diagnosis and treatment in this case? So haloperidol long-term description would always be that tardive dyskinesia, and in tardive dyskinesia, we'll be using valbenazine for management of these patients. Keep commenting, guys. Keep hitting the comment button there. Then is a female, she's having amnesia for past 2 weeks. I mean, the key discriminating factor in this question was 2 weeks after she lost her father in a road traffic accident. So I initially would have thought of this as post PTSD, but if the question mentioned 4 weeks, then it is PTSD. Otherwise, it would be a stress disorder. You know the cutoffs very well, so I don't need to explain them there. It is okay, if it is screening, it is IGF, but then I think that was not IGF suppression, no? So just check out the options on the previous page. Okay. Then is regarding this guy who's very obsessed with this schedule and is wanting to do everything systematically and does not agree with his friends, not ready to seek therapy. So yes, without let's not pick up somebody from a movie or anybody in whom we would have met in a medical college. Let us just quickly comment on whatever you feel like for this one. Yes, guys, quick answers, please. This I would like everybody to hit, because I'm very sure you would have met at least one person like this at some point in your time, either in your medical curriculum or maybe in a hostel, right? I mean, that in our hostel, right? So it has to be. I mean, most of us come across this. Yes, so obsessive and compulsive here. Then was this question again that was a repeat from the FMG exam कि वो 100 किलोमीटर दूर किसी अस्पताल में आ गया and he's acquired a new identity, वो नया आधार कार्ड बनवा लिया, that is dissociative fugu. The answer would be option number C in this case. Then is that delusional perception that the chap is having, that is because he can hear that flapping of birds, and then he says that God is telling me to move. So that's like a delusional perception, and it is like he is seeing the birds, right? So he's seeing the birds and can be hearing those birds as well, but it's seeing the birds. Okay, seeing the birds is what he said, and that would be a delusional perception. Okay. 130 was C, the fugu thing. Then is a patient who's having this headache with projectile vomiting. Fundus shows a papilledema. The CT head in this case shows a dural tail sign. That would be a meningioma. This image, I'm not sure, was for a tumor mass on the left side or on the right hand side. What I could pick up was mass originating from the kidney. So if it is a, I mean, depends on the image. If it's a mass originating from the kidney, we'll go with renal cell cancer. So I think you can give yourself 1 mark for this one. I mean, it depends on whichever organ that was identified there. Then is a question on a patient of low backache, and you notice that the spine, the vertebra, I mean at the lumbosacral area, you can notice that the sacrum and then the lumbosacral spine, the vertebra is displaced anteriorly. That would be a spondylolisthesis. I initially thought that the question would be on pneumonia, but then there's fever, chest pain, and there's a tracheal deviation that is also described in the patient, as you can see. And along with that, there can be a slight concavity which is present here. So considering that part, we'll say this is right upper lobe collapse. Then was a barium swallow. And he said, what is the marked structure which is present here? That would be right at the bottom. I mean, you can pick up that epiglottis, and then piriform sinus is what can be picked up subsequently. Then is a question on this painless tumor in the neck, which is originating from the carotid body, and then the characteristic manifestation was given. I mean, this description was, which is very classical, that if you press on the carotid artery below the swelling, the tumor will disappear. But when you remove the pressure, the tumor will again fill up with blood. I mean, that's one of the main diagnostic features of this particular tumor. That is a carotid body tumor. And what is present here is a Liar sign, because when the tumor will increase in size, it will cause a splaying. It will cause separation between the external carotid and the internal carotid artery. We have a common carotid, external, internal carotid. Thus, the part would get those two parts would be totally separated. The next question that we're dealing with is a patient of Paget's disease. I mean, he mentioned increased heart size and serum alkaline phosphatase being disproportionately elevated. The combination of the two would help us in analyzing, and warm bones also described. That would be high turnover state, pulsations. Okay, so I'll just add that pulsations in the bones can be felt. Warm bones, pulsations in the bones can be felt. So that goes in favor of Paget's disease. Then we have a guy who had a motorbike accident, and he's having those P's that are coming up. No, like we have that pallor, paresthesia. I mean, that paresthesia is described. First, dorsal web space sensation is not coming, and then we have pulselessness. So initially, at the moment, like the pulse is present, but gradually the pulse will disappear. So this would be a compartment syndrome that is developing after a injury, a bike accident, or a crush injury. And for any patient having a compartment syndrome, if in developmental phase, we'll have to go in for a fasciotomy. Okay, fine, got it. I'll remove that pulsating for the previous one. Yeah, doctor, that is like self-explanatory, because the tumor is originating from the carotid body, so that's why the carotid, the pulsatile nature of the mass. Okay, I'll just add this here anyway. That gives more credibility to my diagnosis. Okay, so we are on road traffic accident with a mid-shaft fracture of the femur, and there's a breathing difficulty. That would be fat embolism syndrome. GERD criteria being satisfied there. I mean, the unconsciousness in a patient. There is a rash described. You guys are, and did he say unconsciousness? Yeah, breathlessness, tachycardia, petechial rash. But yeah, at least the two major criteria are getting satisfied in this case. Then is a kid who's having a painless limp. X-ray of the bilateral hip is shown. Interpretation between two close answers. Either it's going to be developmental dysplasia of the hip or TB hip. If you check out the X-ray that I could pick up, was like the head of the femur on the left hand side looks compressed, and the joint space on the left side really looks relatively increased. So this would go in favor of like Perthes disease. That would be avascular necrosis. And for developmental dysplasia, there would also be physical appearance of the acetabulum would be having a acetabular hypoplasia present. So the radiological differences are present based on like whatever was, I mean, obviously it is not SCFE or TBA, because both of them would be having presence of pain. So it is between Perthes and developmental dysplasia of the hip that I had to consider. And considering the options which are given here, I mean, I'll go by Perthes based on the X-ray findings which are given in this case. And DDH is developmental dysplasia can be bilateral as well, doctor. We can't predict on the basis of that. Okay. Then is a knee replacement that was done 7 days before, and the reliable diagnostic test in this case. So the patient is having a pulmonary embolism. This is going to be like knee replacement, and I'm suspecting a massive pulmonary embolism occurring. So I'll do a CTP in the guy to pick up a big clot that could be obstructing the pulmonary artery of a patient. Knee replacement surgery implies that the person can end up with deep vein thrombosis. The reason for deep vein thrombosis is prolonged immobilization of the patient. Okay. Then we have this Dermat question with respect to non-progressive hypopigmented lesion on the trunk. And wood lamp examination shows a white accentuation. Diascopy is negative. The diascopy negative tells us that the vascularity of the lesion is not present. So the correct answer in this case is nevus depigmentosus. I think it's fighting between B versus C only, because it is mentioning that the lesion is present since birth. As far as option number A is concerned, it would be developing later. But if we are talking about a lesion that is present since birth in a patient, it is B versus C. And then based on the findings of the wood lamp and the diascopy report being negative, it will go for nevus. CTPA is CT pulmonary angiography. Yeah. Okay, doctor, like, I mean, that there can be differences of opinion. If it is not even present since birth, even then, if it's like a single lesion like this, I'd not call it vitiligo for this one. And the physical appearance of vitiligo is much more grossly different from the single lesion which is given in this patient. Then is a question on lupus vulgaris because he's mentioning apical calcification in a chest X-ray. I mean, any Indian patient with a calcification in the X-ray and a skin lesion will think in terms of skin tuberculosis. And for skin tuberculosis, we'll go in for a PCR to be 100% sure. Slit skin smear would be more useful for diagnosis of leprosy, though we can use it for TB also. But then at the same time, the split skin smear sample may not be adequate due to operator-related issues. So let's select the best one. I mean, we'll not rely on doctor's experience or the technician's experience. Will rely on technology for this case. No, doc, I don't think so. This was a question on leprosy. I think this was a question on tuberculosis because X-ray is showing apical calcification. If it was leprosy, then the lesions would be grossly different. So, I mean, and yeah, split skin smear because we're taking a sample from the dermis only. No? So I'm saying if we can scan the dermis for Mycobacterium leprae, we can scan the dermis for Mycobacterium TB also. But then the point is that the sample is not adequate and you have to do it from multiple sites. So there can be error of judgment and therefore like uh, PCR there. Okay, cool, doctor. Fine. Then there is the irregular. I mean, this is that beggar's foot that we always discuss, Madhura's foot, as they describe multiple sinuses and black color granules. That black color granules is solving the answer to this question. We are thinking in terms of eumycetoma, where we have the septate hyphae of 4 to 5 microns. The answer in this case would be option number D. If it was white or yellow sulfur granules, then it is actinomycetoma. Okay, then the most common cause of squamous cell carcinoma of the base of the tongue would be HPV. This is again a FMG question repeat. Like they, in there, they did not mention the tumor at the base of the tongue. They just said HPV commonly causes which cancer, and there was no cervical cancer they've given. It was oropharyngeal cancer and laryngeal cancer. And between oropharyngeal laryngeal, it would be oropharyngeal. And for you guys, the question was like base of the tongue. So same question like old wine in a new bottle. That is the kind of question that was put up. If the question talks about hairy cell, I mean, it talks about that hairy tongue appearance, no, that can be seen with the Epstein-Barr virus in a HIV positive patient, then it's a totally different ball game. But if he's talking about a cancer, then it's gonna be human papilloma virus. And on the lateral, yeah, on the lateral border of the tongue. Okay, so base of the tongue or on the lateral border, that's okay. In fact, the cancer would be more common on the lateral border. Then is painful vesicular lesions. The moment you read that, you know that you are dealing with herpes simplex. Every time painful vesicle lesions, grouped vesicles in a dermatomal distribution, this would always, and he has mentioned about the multinucleate giant cells as well. Then is a patient who had an airway obstruction and the mouth is filled with the concrete debris. There's a hypotension. You need to secure the airway of a patient. So what we can do in this patient is one, a tracheostomy, but I mean, the procedure that we're talking about at the moment is a I mean, we first need to do a cricothyrotomy in a patient and then subsequently like a tracheostomy can be done. Hit me up with the comment there with respect to like whatever you commented or answered for this question, guys. Yes, guys, quick answers, please. Okay, so we're talking about a cricothyrotomy, but this must be followed up by a formal tracheostomy. It cannot maintain airway for 6 hours. No, I mean, for a few minutes is understandable. It's only a needle, right? So when we do a needle cricothyrotomy in a patient, then it would not be a procedure which can sustain for hours altogether. So the correct answer would be B. Next is a question on malignant hyperthermia. MH, because there's a muscle rigidity and increase in body temperature. It's related to ryanodine receptors, as you know, the abnormal calcium entry. And for the treatment of this condition, we shall be using dantrolene sodium. Okay, so that was the scheme that you guys can have a look at in case you would be interested. Then is a patient who receives a muscle relaxant and there's like vasodilation, flushing, histamine release. I mean, every time we read about those histamine release related manifestations after muscle relaxant being given, it has to be a trachurium. For 152, we have a patient with febrile seizure. It's a GTCS that is described, and the main treatment for this chap would be diazepam. I mean, if somebody has come in the casualty in the hospital setting, he's coming ER, generalized seizure, GTCS, we have to secure IV line, we have to give IV diazepam to the patient. For the next question, I'll go by the PSM teacher's word. I have absolutely no clue with respect to this, but what they told me was that for 7 months of age, what would be recommended would be something between like half to one katori, 3 to 4 times per day. And among the remaining options, I was just thinking to myself, how can a child be eating? So children nowadays are such fussy eaters, that's a separate issue. But to make a child eat 5 times, 6 times per day would be a very, very far-fetched issue. So I think uh, 3 to 4 is like a much more, a better way of answering this. For the 154th one, I again have a reference. I've highlighted the answer also because there is a secondary hyperparathyroidism. Patient is having chronic kidney disease and there's a secondary hyperparathyroidism. The calcium values in the patient is less, the phosphate is elevated, and phosphate is a very dangerous product. It will contribute to calcification. It will contribute to kidney stones in the patient. So what we need to do in this patient is one, give this patient calcium. The calcium that we will give in this patient is calcium acetate, or instead of calcium acetate we can also be giving is calcium carbonate, and both of them will act as phosphate binders as well. We don't start with vitamin D. Now the query in your mind would be, why would we not be giving vitamin D to this patient? Because in kidney disease it is vitamin D that is less, so we should first give vitamin D to the patients. I agree to your point. But look at what Harrison says, and this is what I've explained in my routine videos or I mean any revision programs also, that जो अगर इसको विटामिन डी देंगे ना तो उससे कैल्शियम का लेवल स्पाइक होगा और फॉस्फेट के साथ चिलेट कर जाएगा. कैल्शियम और फॉस्फेट का मल्टीप्लिकेशन प्रोडक्ट कभी भी अगर 55 को क्रॉस करता है तो दे कॉज एक्टोपिक कैल्सिफिकेशन. यू कैन हैव कैल्सिफिकेशन इन द टिश्यूज आल्सो. तो बोलता है कि पहले आप इसको जो मेडिसिन दोगे दैट वुड बी calcium acetate, calcium carbonate and phosphate binder to be given to the patient. And along with phosphate binder एक और दवाई मैंने बताई हुई है, that is sinacalcid, which should be given to the patient. And after that I've talked about like vitamin D to be given to these patients. So even if you listen to the CKD component, in fact there were two primary aspects which I want to bring to your attention. Both are picked up from Harrison. One is the treatment of anemia in CKD. If he says in CKD patient there is a presence of anemia as has come up in the paper, if he says पहले क्या करेंगे, तो first it is iron and then it is erythropoietin that would be given to this patient subcutaneously. And if a person is having CKD and is having secondary hyperparathyroidism with low calcium and more phosphate, then first we need to do is provide him with calcium what is less, because they can be tetany-like manifestations. And the additional aspect of calcium will be it will act as a chelator agent, plus I can give drugs to the patient, tinapor, or instead of like talk about common sivalemer, lanathum carbonate that I've talked about. So it is phosphate binders that would be useful in these patients. The correct answer in this case is option number B. The reference of Harrison is given here in front of you. Okay, then is a question on respiratory distress in a newborn child, and there is no marking of the diaphragm. So there is the herniation of the intestinal contents into the chest of the patient. Because of the herniation of the intestinal contents into the chest, that would be congenital diaphragmatic hernia. The differential diagnosis of this is a CPAM, for which the diaphragm outline should be visible. If the diaphragm was visible and you are seeing malformations like round down lesions present in the chest, then it is cystic adenomatoid malformation. CAM उसको बोलते हैं. That cystic adenomatoid malformation के लिए diaphragm की जो wall है वो easily identifiable होनी चाहिए. But if the diaphragm is not visible and it's like a abdominal wall continuous with the chest, then we have to answer this as congenital diaphragmatic hernia. Had a 2-year-old kid. He was unconscious and this kid was aspirating a peanut. He had coughing, so in unconscious, and it's a 2-year-old child, so it would be a abdominal thrust. If it was infant, I would have thought about back slaps as well, but considering 2-year-old child aspirating on a peanut becoming unconscious, I'll go with the abdominal thrust considering the age group of the patient. I mean, if it was an infant, then I'm okay with this. I mean, if you answered B for back slaps and thrusters, I'm okay with it if it was an infant. But if it's a 2-year-old kid, we'll go by like abdominal thrusts in this case. Then is a question on menstrual cycle. I think this would be a combination of physiology or gynecology that would come up here. So we know that obviously in the later part there would be high progesterone and there would be low estrogen and the LH and the FSH, because LH peak has already occurred. No, LH peak is responsible for ovulation at the 14th day. So the hormones would be decreasing. So this would be option number A. This is a graph which is usually given in physiology and has been replicated here. Then was a question on controlled cord traction. I think the obstetrician has talked about it. Then there was a question on this cord prolapse. So for cord prolapse, you have to take the patient back into the OT only. I mean, there would be no way a normal delivery would be possible. So try to, I mean, way to minimize the cord prolapse, place the patient in a Trendelenburg position and then prepare the patient for OT is what we'll be doing in this case. A patient with endometrial thickness of 16 mm, I think the cutoff is 12 millimeters, so we'll do endometrial biopsy. Here it is 4 grams IV and then it's gonna be 10 grams intramuscularly. That would be given to the patient, total of 14 grams by the Pritchard regimen in a case of eclampsia. Then was an interesting one, postpartum hemorrhage, which is not responding to initial medical management. And he said, what will you do in the labor room? So labor room mein to main, I think I discussed this question in the FMG recall also, that I think this is again a repeat from the FMG exam. कि labor room में क्या करेंगे, तो we have to go for balloon tamponade because in medical therapy is not working. Oxytocin दे दिया आपने, ergometrin का इंजेक्शन लगा दिया, bimanual compression कर लिया, but that bimanual massage will not work in that case. And like he has written the word sutures also, but this is not like a cervical tear that I'm talking about. It's like a bleed, gush of blood occurring from the uterus. So for that I need to deploy a Buckley's balloon here. I mean, that is what they always talk about. You know, obviously the final treatment, last resort would be a uterine artery ligation that would be done in a patient, or like hysterectomy. That's like the last resorts that we're talking about. But in the labor room, what we're doing is a Buckley's balloon tamponade in this case. Then is a question on fetal distress. I think there were two of them on fetal distress where we'll go for an emergency cesarean section. Yep. I'll talk about the next one as we progress. This is a postmenopausal lady with a painless vaginal bleeding, and what is the likely diagnosis in this case? Yes, guys, keep the comments going, man. Keep the comments going. Painless vaginal bleeding in a woman. So the lesion that we'll be considering in this case. Yes, guys. No, chest compression या foreign body में तो भाई chest compression नहीं देंगे यार, ये तो मैंने बताया हुआ है कि foreign body के केस में तो chest compression नहीं देंगे ना. We'll have to go in for a MLH or we'll have to go for chest labs and back thumbs in a patient. Okay. Yeah, postmenopausal woman, vaginal bleeding, will think in terms of endometrial carcinoma. Then is the ACOG guidelines for NST, the non-stress test, which has to be done for at least 2 observations should be there, 20 minutes each. I think one test was inconclusive, and therefore we have to evaluate for another, 2 scans should be done in a patient. Then is a trial of vaginal delivery. The patient is 8 centimeter dilated, fetal station at -1, and there's a fetal distress again. Yeah, this is the question I was saying. I mean, there were 2 which I think even with the minimal obstetrics knowledge I can do, because fetal distress, I know that, you know, we have to go in for a cesarean section. So I think those were easy pickups there. Then I think 168 and 166 were same, or they're slightly different, but in one there was a specimen that was described. So considering the specimen of the uterine wall, where the wall looks very unhealthy, I would say we'll go by carcinoma endometrium. So I think 166 and 168 would be same. So count goes to 190 in the document. Then is shoulder dystocia, that is Mac Roberts. Then is repair of episiotomy that you would have done multiple times in your OBGY postings. Mucosa, thin layer में stitch करना है, mucosa, then muscle, and then the skin. MRI will be deciding the input. If it's a well circumscribed mass, then I'll go for fibroid. But if it's gonna be like a mass like this, where you can see multiple white spots, that would be endometrial tissue in the normal myometrium, that would go as adenomyosis. A lady is having postmenopausal woman with hypertension is having vaginal bleeding. If she would have come to a government hospital, they would have sent BP control karao, but obviously you are not gonna refer her and say कि पहले BP control karao. You'll manage her aggressively. That would be a pelvic examination, perhaps where a transvaginal ultrasound. You know, the interdepartmental fights that keep on happening, where we keep on, like, as residents, a lot of wrong things are also done, like they want to brush off the patients and send it to the alternative departments. Okay. Then is a patient of secondary amenorrhea with ultra low anti-Mullerian hormone levels. You know, normal value is going to be 1 to 4. Here it is going to be very less. So we'll talk about a premature ovarian insufficiency. For evaluation of this, I know from my even background knowledge of OBGY that every time there's like a first trimester ultrasound, there would be a CRL that would be checked. That is a crown rump length. D-dimer ऐसे बच्चे, it is positive in fat embolism, it is positive in COVID, it is positive in D-dimer ऐसे is positive in pulmonary embolism, fat embolism, it is positive in COVID-19 pneumonia. So because it's just related to microthrombi formation, it cannot help in diagnosis of any condition. We have to go for a CTPA for a diagnosis of pulmonary embolism. Okay. Why pulmonary बच्चे, we will not do pulmonary angiography. I did a CTP है ना, that is a CT pulmonary angiography. बच्चे ये highlight किया हुआ है कि pulmonary embolism का main test होता है. Okay जी, so we are having a patient who was having pituitary microadenoma with elevated prolactin, and prolactin is then gonna be inhibitory to release of LH and FS, and that is why we would be having is amenorrhea and development of infertility. So the answer in this case is decreased GnRH secretion from hypothalamus. Prolactin has an inhibitory effect on LH-FSH. That's what he's trying to see here. Then is cervical cancer causing hydroureteronephrosis. You know, cervical cancer, the leading cause of death is kidney failure. So therefore, we'll be going ahead with the answer is stage 3B. The staging part is always easy. Lopsided maneuver, I think you were able to answer. This is a question which I'm not sure about the options. There were different versions present. So I think you would have done it right. Probable versus confirmed pregnancy, because the diagnostic criteria turn out to be different, but there is no fetal heart sound that is present here. So if it's not a fetal heart sound described, I'll go by like probable pregnancy in this case. Okay. Then we have this lady who's having this inflammatory carcinoma. The inflammatory carcinoma is involving whole of the breast. I mean, if the whole of the breast, this is again a FMG repeat, guys, that here I think for you guys, they gave an image there. They did not give an image. There was just information regarding inflammatory carcinoma involving whole of the breast. And in those circumstances, it would be T4D that would be given. If it's just a pure orange appearance, then we'll go by T4B. Okay, great. Then is a patient who's having this bird beak appearance, that is a achalasia cardia, because even if I don't say achalasia cardia, I can say that there is a query motility disorder of the esophagus. So considering a motility issues in the esophagus, we have to go in for a manometry. The knot which is given here is having these multiple ones, right? So it would not be a granule or reef because of the multiple intertwining things that would be happening with respect to this. Therefore, this would be answered as a surgeon's knot. Then a question on varicose veins, like C6 stage is gonna be like related to venous ulcer. So what we can see here is not a venous ulcer. What we can see here is varicose veins, the prominent veins that can be picked up. Sclerotherapy is not used. It's like a endovascular treatment that is done nowadays. So he's asking us about what would be correct. And the usual cause for this is, I think, idiopathic. So the correct answer in this case will turn out to be lipodermatosclerosis. That would be developing the pigmentation that would be present. Yeah, maybe the suture was not given. Okay, you're talking about that image of the suture. Maybe there might be a different image, doctor, but like we have to identify the knot basis of that. Then we have a kid who's having ballooning of the prepuce on micturition. Again, a FMG repeat. Every time there is like, the always phimosis and paraphimosis पे कहानी फंसती है. Paraphimosis is where the glans penis skin will go back and it would not come back to normal. But if it's like ballooning of the prepuce on micturition, we'll go by true phimosis in this case. So the answer would not be paraphimosis. Then you're aware of the types of fistula and ano depending on whatever was the image that was given. Some guys said that the image was with respect to the one that is shown here. That would be the type 1 intersphincteric one. But if it was a different image, then your answer would have been proportional to the same. The ballooning of the prepuce. Okay, I'll add that, doctor, that metal stenosis. Okay. But there it would only be a narrow stream, right? It would only be a narrow stream that would be present. So we'll still go by phimosis as a more appropriate terminology to be used. Okay. Then they asked about a suture material which was purplish in color. That would be PDS and that would be monofilament. I think the name was, brand name was given, I think. So from that you could pick it up. Again, a very easy question. I think that has a medicine and a surgery overlap. Thyroid specimen was given and complication after 3 days. So there would be inadvertent parathyroid resection. And because of the parathyroid removal in the patient or parathyroid resection in the patient, there would be a development of hypocalcemia. That would be tetany-like manifestations. Everything else in the question would be occurring in the first few. I mean, B and C will occur immediately and recurrent nerve palsy would be coming to notice later. But like complication that occurs after 2 to 3 days would be a carpopedal spasm. Then is a patient with jaundice and weight loss found to have pruritus with scratch marks. Scratch marks, that is obstructive jaundice, where we get a lot of pruritus, and it's distended gallbladder. So distended gallbladder is always a feature of Courvoisier law, and Courvoisier law always means that there has to be a malignancy in place, and that malignancy is obviously not carcinoma of the gallbladder. The gallbladder does not become palpable in a gallbladder malignancy, but becomes palpable in a carcinoma of the head of the pancreas, where there's an obstruction at the level of the ampulla of Witter. So the answer in this case would be option number B. Then is Strasbourg type of bile duct injury. Again, a repeat from the FMG paper, I think. maybe not this time, but they've asked about a similar kind of image or recall. And among the four varieties, I think the injury would be occurring in the cystic duct, so it would be type A. Otherwise, if the injury is occurring to the aberrant right hepatic duct, then it would be answered as type C. So depending on wherever the location of injury was described, you can answer it accordingly. Then is a patient of full thickness burns, and the person will end up with development of contractures. So what we will do in this patient is S-cherotomy, and this S-cherotomy would be done for circumferential burns. So I think there was a similar kind of an image where there was a dummies that was described, and that is the best that we could pick it up here. Okay. Then is penetrating trauma with hypotension. I asked multiple people with respect to कि blunt trauma abdomen था, penetrating था, so there was no blunt trauma. So that's why like E fast I'm ruling out. And because there is hypotension in our current patient, so we need to straight away take the patient to the OT and go ahead with the exploratory laparotomy. And the last one that I have at my disposal, so there's still 9 in the mystery, which like I have totally avoided any kind of repeats, as you can see in the discussion. The last one that I have is anal canal lesion. So if it's an anal canal lesion, I mean, especially at the anal verge, right? So the lower part that is below the white line of Hilton, the part that is below the white line of Hilton will drain into, that would be a superficial inguinal one. So I think I have like 191 at my disposal at the moment that I have tried to discuss with you. And thank you so much for your patience and joining for the discussion today. पेरिटोनाइटिस भी है तब भी, हाँ जी हाँ जी, ऑल द मोर रीजन मैम, अगर इंटेस्टाइन फट गया, अगर इंटेस्टाइन में छेद हो गया, पेरिटोनाइटिस हो गया मरीज को, तो दैट वुड ऑलवेज बी इवन मच मोर रीजन व्हाई आई विल बी गोइंग अहेड. लेट मी जस्ट ब्रिंग दैट क्वेश्चन टू योर अटेंशन वंस अगेन. Yes, okay, I missed. Yeah, there. So if it's a peritonitis which is present in a patient, it gives even more credibility to me going ahead with the exploratory laparotomy. So great guys, great going. We did a rapid fire session today, and thank you so much for joining for the session today. You have to type. What I'll do is I'll send in my email ID at the moment, and any question with options, if you can recall, that's perfectly fine. Otherwise, we can call it quits for today. Okay. Nikki, the answer for that hypertensive lady with the checkup would be to first do a gynecological evaluation. That would be a pap smear, and then evaluate our uterus for the source of bleeding there. Okay, fine. Thank you so much, guys. It was really fun interacting with you. Bye bye. Take care. God bless you.